Right. Good morning, everyone. Good afternoon or good evening, wherever you are. Welcome, and thank you for joining Malaria Consortium's webinar, Let's Talk, how the community dialogue approach helps communities to achieve better health. So over the next 45 minutes or so, we will talk. We will talk about social and behavior change, we'll talk about community engagement, and we will talk about one particular approach that Malaria Consortium has used in different countries, in different contexts, the community dialogue approach. Let me briefly introduce the speakers and panelists. So my name is Christian Rassi. I work with Malaria Consortium as a program coordinator in London, and I've been involved in several implementation research studies exploring the use of community dialogue. First up to present will be James Tibenarana, who is Malaria Consortium's Global Technical Director, who will set the scene for us by talking about why we think social and behavior change is important to achieve universal health coverage. James is normally based in London, but he's joining us from Bangkok today. I'm joined here in London by my colleague Lauren Smith, who is Malaria Consortium's social and behavior change specialist. And Lauren will give us an overview of what social and behavior change is all about, and then introduce Malaria Consortium's community dialogue approach. And we will then hear from two countries where we have used the community dialogue approach in the past. So I will talk about a project in Bangladesh, where we aim to improve the appropriate use of antibiotics at community level. And next, my colleagues Sandrine Martin and Junica Alfa, so both based in Mozambique, will tell us about a project that uses community dialogue to improve prevention and control of neglected tropical diseases. Just before we start, a little bit of housekeeping. In the second half of the webinar, we will have time for questions and answers. If you have any questions for the speakers or the panelists at any time, you can type them into the webinar app using the Q&A tab. There should be a button at the bottom of your screen. And we will be picking up the questions you're submitting, and we'll try to answer as many of them as we can towards the end of the seminar. If you have any problems or questions with the app itself, please type them into the chat tab, and then one of my colleagues from Malaria Consortium's external relations team will try to resolve any issues you may have. And you can also use the chat tab to share comments with all the webinar participants if you wish to do so. So I would now like to invite James Tibenarana to get us started. You may know that we marked Universal Healthcare Day or Health Coverage Day yesterday, and James will discuss why we think social and behavior change matters if we want to achieve universal health coverage. Over to James.
Thank you very much, Christian, and welcome everybody to Malaria Consortium's first webinar series. As Christian has mentioned, yesterday was Universal Health Coverage, and the theme is Unite for Universal Health Coverage. Now is the time for collective action. A critical stakeholder within universal health coverage is the community. And yet, community engagement approaches are varied and yield different outcomes. For universal health coverage, we require community empowerment such that the community don't feel that they are the problem, but that in fact, they are also the solution. And by engaging them in putting together the solutions and taking action along those lines of what are the problems, what are the solutions, we do feel that universal health coverage can be achievable. The community dialogue approach provides a platform which makes this possible. And hopefully, during this session, you'll see some of the experiences that we have gained from the work that we've done in two countries, as well as some of the dialogue we've had with some of you who are participating in this webinar. I will not take up too much time, but now hand over to my colleagues to then lead us through universal health coverage and the community health dialogue.
Thanks, James, so much for that introduction. As James mentioned, the community is a key stakeholder in achieving universal health coverage. And while we recognize that the services need to be available, communities and households are involved in adopting recommended behaviors. So the field of social and behavior change is really essential in terms of engaging communities in order to achieve universal health coverage. So the field of SBC came about from the realization that knowing something is good for you is different from actually doing it. So this means that increasing knowledge and awareness alone is insufficient to help someone take action. So social and behavior change is a strategic process directed at mobilizing all societal and personal influences on individuals and families in order to prompt action and help them adopt healthy behaviors. Social and behavior change incorporates lessons learned from public health and health education over the past 50 years. It acknowledges that we need education, persuasion, community involvement and support, and a committed government. And so these insights about how individuals make decisions are very helpful in terms of designing effective health interventions. Social and behavior change also applies theories from disciplines such as psychology, anthropology, cognitive science, and even the private sector marketing strategies. And this helps us to understand how people make decisions, which can ultimately inform our intervention design. So one of these frameworks derived from theory is called the social ecological model. And this really represents that there are many influences on individual behaviors. So this includes the policy or enabling environmental level, organizational, community structures, interpersonal or peer-to-peer communication, as well as the individual level. So social and behavior change strategies use a combination of interventions to work by influencing all these different levels. So really it's an interactive process where we engage individuals and communities and even societies more broadly using targeted and context-appropriate communication strategies to help prompt healthy behaviors. So over time, this process can actually help create a supportive environment, which then makes it easier for individuals to initiate and maintain these recommended behaviors. So the community dialogue approach is one of these social and behavior change approaches, which works at multiple levels, such as that represented in the socio-ecological model. So we really think that this is one approach that can help foster ownership and social accountability for helping to improve health. So the Malaria Consortium developed this approach, and we know that community dialogues have been used in a number of different approaches, and it means something different to different organizations. So today we want to make sure that we're explaining the approach that was used by Malaria Consortium and why we think that it's an effective approach. So to help explain this, we developed a short film, which we will now play.
Sometimes it is difficult for health program implementers to effectively reach the people most affected by disease. Interventions are often designed from the perspective of healthcare providers and not the people they're intended to reach. Diseases and how they can be prevented, diagnosed and treated are often misunderstood. This means that people may get sick more often and might not seek appropriate care. Improving knowledge and understanding of disease alone is not enough to create and sustain healthy behaviors. People also need supportive social environments, which encourage and remind them to take action. In response to this, Malaria Consortium came up with an innovative social and behavior change intervention called the Community Dialogue Approach. In this approach, communities explore health issues, identify locally relevant solutions, and collectively commit to a plan of action. These dialogues are facilitated by community-based volunteers who are selected by the communities themselves. The volunteers are trained on health issues and group facilitation techniques. They are also provided with tools to help them guide the community dialogue sessions. Community dialogue sessions are held on a regular basis, according to the preference of the participants. During each session, the volunteers guide participants through a dialogue where they are encouraged to share experiences, identify challenges, and agree on how these can be best addressed. We believe that in order to be sustainable, the community dialogue platform needs to be embedded in both the healthcare system and community structures. Over time, this approach can help to establish a collective sense of responsibility that is essential for improving health outcomes. We have applied the community dialogue approach across a range of contexts, which has consistently resulted in positive change. We therefore encourage others seeking to effect lasting social and behaviour change at the community level to consider this approach.
So, as with many social and behavior change interventions, the community dialogue approach aims to increase knowledge and awareness of health issues and why the desired behavior is so beneficial. But the approach also addresses the social norms by working with communities to develop a platform to discuss health issues and create plans of action to how best to address these issues at the community level. And we believe that this is the process which ultimately facilitates change in the communities and develops a sense of ownership over addressing these health issues. So the approach has four key principles which underscore the approach. And the first is that it's grounded in theory and context. So it actually uses known behavioral theories and as well as evidence from the local context. It's also embedded within existing structures, so both the community structures and the healthcare system. And also, as mentioned in the video, it establishes social accountability, meaning that all stakeholders, including community members, play a vital role in improving health. So we believe that this approach over time can contribute to behavior change at a population level. So not just those who participate in the community dialogue sessions themselves, but more broadly in the communities. So first, this happens when participants attend the community dialogue sessions and discuss the health issues that are presented, and as well as how those affect them in their everyday lives. And second, this dialogue essentially continues with the broader community, and over time, this kind of process can shape social norms in terms of recognizing these health issues and how they need to be addressed. So while we acknowledge this approach has a lot in common with other SBC approaches, we don't want to say this is the best approach or that it should be used alone, but basically that these principles are important for all SBC interventions. So we've also applied this approach in different contexts, and the results from that have shown that it's highly relevant in different contexts and can be used to address different health needs. So our next speakers will talk more about this and how the approach has been contextualized in different contexts. So first we'll hear from Christian about the community dialogue experience in Bangladesh.
Thanks, Lauren. I want to spend the next couple of minutes sharing our experience of implementing a community dialogue intervention in Bangladesh to address antibiotic resistance. We are conducting this project, this study, in collaboration with the University of Leeds and ARC Foundation. And the starting point for this project was really that the University of Leeds and ARC Foundation had done some work in the past to help community health workers to appropriately prescribe antibiotics. And they've been very successful in doing that, but they recognized that there was an element missing, a because they hadn't addressed the demand side. So that was the starting point for this intervention, and we realized that community dialogues might be an appropriate way of trying to strengthen the appropriate use of antibiotics at the demand side. So this project really aims to develop, adapt, and pilot test the community dialogue approach for preventing and controlling antibiotic resistance in Bangladesh. The key messages that we're trying to get across, especially during the first stage of each community dialogue meeting, which is about exploring the issue, are really based on WHO recommendations for what the general public can do to reduce the impact and limit the spread of antibiotic resistance. And just to give you an idea of what those messages are, so it's about not using or only using antibiotics when prescribed by a certified health provider, never demanding antibiotics if a health worker says that you don't need them, not sharing or using leftover antibiotics, and preventing infection, for example, by hand washing. So all of this sounds simple and straightforward, but it can actually become quite complex when you think about how to contextualize these messages. So just to give you one example, only use antibiotics when prescribed by a certified health provider. Now, in a context where regulation is poor, the meaning of the word certified becomes fairly meaningless. So we spend a lot of time working with communities and policymakers to define what certified health professional actually means in the Bangladeshi context. One more example, in Bengali, in the Bengali language, there is no word for antibiotics. So it was really difficult to define what we mean in simple, understandable terms by the term antibiotics. One core objective of our study is to assess the feasibility and acceptability of embedding this approach in existing health systems and community structures, and I'll tell you a little more of how we try to do that in a second. So here's what we did. We implemented this intervention in the catchment area of 5 community clinics in a district called Comilla between April and November 2018. The total population of the study area was about 30,000 people. We trained a total of 55 volunteers and 15 supervisors who between May and July, which is the latest data we have at the moment, we're in the process of collecting final data, but the data we have at the moment take us up to up to July, and we can say that up to July, 200 meetings have been conducted by the 55 volunteers. In the Bangladeshi context, we decided that it would be appropriate to have separate sessions for men and women, hosted by volunteers of the same sex. And the way we tried to embed this intervention in the existing health system was that we recruited supervisors from among community groups who are linked to the network of community clinics in Bangladesh. Next slide, please. So here's just a few examples of the images we used to illustrate the key messages. So we're very happy to share them with whoever's interested. So this is really just to give you a quick flavor. Some preliminary findings. We're currently in the analysis and write-up stage. So for now, these findings are preliminary. But what we can say is that the volunteers and the participants generally enjoyed the community dialogue sessions. They were very well attended, around 40 participants at each meeting. Participants very frequently reported examples of how their own behavior had changed. So for example, not sharing antibiotics with family members. There's a quote on the slide here, which shows that a woman who participated in the dialogues fell sick, and her mother-in-law offered to share antibiotics with her, but she refused because she'd learned that that wasn't a good idea. And many of the communities that participated in the intervention also recorded collective decisions they'd reached of how they wanted to reduce antibiotic resistance locally. So for example, communities reported that they commit to taking the full course of antibiotics as prescribed, or always seeking care or seeking the diagnosis of a community health worker. Some success factors we identified. So we think volunteerism is really important. It's important that the volunteers are from within the communities, because we think that really helps establish a sense of community ownership. And we also think it's important from the point of view of sustainability. Then we put a lot of effort into trying to make this intervention as inclusive as possible. So for example, all the facilitators, all the volunteers and their supervisors went through an exercise where they mapped out their communities and they looked at the different sections of the communities, the different groups that exist within the communities, and they came up with strategies to include as many of those groups as possible to make sure they were represented in the community meetings. And we also feel that the support from the supervisors who, as we say, are linked to the existing health system through the community clinics in Bangladesh. We felt it was important to have that system in place to help the facilitators, the volunteers, address technical questions and also resolve challenges and conflicts. Now, of course, there were also challenges. The main challenge, we would say, is probably the novelty of the concept of community engagement. People are simply not used to turning up at a community meeting to discuss and have a dialogue. They're more used to being spoken to. So it took quite a long time for the facilitators, for the volunteers, but also the participants to get into this kind of approach. We did see over time, though, a marked improvement in the degree of active engagement from participants in community dialogue meetings. And it was very much down to the skills of individual volunteers. Then another challenge, of course, was the complexity of antibiotic resistance as a behavior change topic. As I mentioned earlier, it starts with not having a word for antibiotics in the local language, which doesn't help. So we really had to continuously refine and reinforce the key messages, again, in a very participatory way, together with volunteers, community members, and policymakers. Overall, though, we would say that the approach has a lot of potential, and it's also created a lot of interest on the part of policy makers. So early next year, we will have a 2-day retreat with the Ministry of Health in Bangladesh to talk about next steps for this approach. Thank you very much. That's the experience from Bangladesh, and I now hand over to Sandrine in Mozambique.
Good afternoon, everyone. I think Christian has described quite in detail piloting of a community dialogue approach in a specific country and context. And I'm going to talk more about how we actually engage stakeholders in Mozambique into piloting and then refining a community dialogue intervention for neglected tropical diseases. So neglected tropical, can I have next slide? Yeah. Neglected tropical diseases are diseases of poverty that affect people who live in remote and very vulnerable areas. So very vulnerable to NTDs, to neglected tropical diseases because of their living conditions and because mainly of the social cultural determinants of health, as we call them. So in Mozambique, the prevention and control of NTDs is a big challenge, especially in the northern part of the country. And although there has been efforts to deliver prevention and control interventions, there has not been much attention given to looking at communities' experience and understanding of these diseases, so that we can actually not address only the biomedical aspects of the diseases, but also their social and cultural determinants. So this is a gap we're trying to address. Next slide, please. In 4 districts of the Nampula province, which is situated north of Mozambique, this is one of the most affected provinces in the country with NTDs, and also one of the most populous one, which has about 1/5 of the whole country population lives in Nampula province. So we've been implementing since 2014 a project jointly with local health authorities and the Ministry of Health to try and enhance community understanding and community participation into prevention and control efforts for neglected tropical diseases. Next slide, please. Yeah, so we initially started in 2014 with a piloting and operational research where we tried to adapt a community dialogue approach model that was developed for childhood diseases to the neglected tropical diseases context with a focus on schistosomiasis. The results of the pilot were quite encouraging, both in terms of increase in knowledge levels around the diseases, attitudes around prevention and treatment practices, as well as feasibility and acceptability of the model, especially among our main stakeholders, who were the district, province, and national entities program managers. So from there, we evolved towards a last phase that started in April 2017, where we are trying to refine, to support the Provincial Health Directorate, to refine the community dialogue approach into something that can be really led by the province in terms of implementation. The whole objective is to have a community dialogue model that is really something that can be implemented and integrated into the routine activities of the national neglected tropical diseases program, and overall the health interventions done at local level. So we've been working with stakeholders, and really I want to emphasize here the importance of working hand in hand with them and all the insights they had into the redesigning of the program and the designing of materials. Next slide, please. So in terms of developing materials for this community dialogue, well, we're talking to low literacy audiences, right, who have very limited biomedical knowledge about these diseases. So it was really essential to have visual materials that would stimulate discussion during the community dialogues and that people could really relate to. It was the first time that materials were developed for these diseases in Mozambique beyond the typical posters of extreme cases that you sometimes see in health facilities or during mass drug administration campaigns. So we worked with the province and district stakeholders to actually identify feasible prevention, treatment, and control practices that people could discuss at local level and implement at local level. So it was not only about improving their understanding of the diseases, but also gaining more self-efficacy in terms of how they can themselves at the village level improve how they prevent these diseases in their homes, in their community, and what they can do to, not to treat them themselves, but to actually ensure that they have access to treatment and preventive services. So to develop these materials, we conducted formative research, but we actually drafted the materials to be integrated into the formative research using projective techniques, because people have very low knowledge about these diseases, so they couldn't talk about schistosomiasis in a focus group discussions. Instead, we proposed some draft visuals of how these diseases are showing people, are acquired, or what kind of consequences they have, to explore more in depth people's perceptions around where do these diseases come from and what they can do to deal with them. So I'm going to show you some samples of the materials. Next slide, please. These materials are available on Malaria Consortium website. They're in Portuguese because it's the language that is mostly used in Mozambique, but we are in the process of translating this into English so that they can be made widely available to other countries' organizations who wish to use them. So the materials are composed of a flip chart, a visual flip chart that the community dialogue facilitators use during the dialogues to stimulate discussion with their audience, with the groups, around the disease's symptoms, the risky behaviors versus the protective behaviors, and try to reach consensus on what are we going to do to try and better control these diseases. And also a guidebook that provides facilitators with some facilitation tips to run participatory discussions in their communities, as well as basic facts about the key messages that are in the flip charts, so they can build on the discussion. I'm going to pass the ball to Junica, my colleague who is based in Nampula province, who has been implemented this approach closely with our partners from district and province level. And maybe she can tell you a little bit more about how we redesigned the community dialogue model that was first piloted in the first phase to make it really province-led. Junica, your turn.
Sandrine, I don't think we have Junica on the line, so maybe if you could just take over Junica's part.
Yeah, sorry, we have some connections problem with Nampula. So our objective, next slide please, was really to develop a community dialogue implementation model that can be implemented by local implementers, that they own it, and that they can integrate that into their own routine activities. So as a first step, we had to work with the district health teams at local level to really identify one person in the district health team who would be like the focal person for implementing and following up on these community dialogues. And this was really key, where we identified one, mainly the NTD's program manager or the person responsible for that at the district, but also to identify a colleague of him within the district health team in the health promotion department who could support him, and they could substitute each other. And that was really key as we involved these figures from the district level in all phases of the formative research and the design of the community dialogue approach. And this culminated in a co-design workshop that was held with these district focal persons and with the province level and some national level representatives as well, to really refine the proceedings of the approach. For this, we used a tool that is called the Tiger Checklist that helped us to write up the different components, key components of the interventions. What is the objective, who is delivering, how, when, how often, using which tools. And this was very useful. It allowed the local implementers to really have concrete and practical inputs into things that should be refined. For example, they refined the criteria for selecting community-based dialogue facilitators to ensure that communities would actually identify the best suited persons. They also specifically tweaked some aspects of intervention, such as feedback meetings that we have regularly on a quarterly basis with community dialogue facilitators, where they said that these meetings should be really held at the health facility level and not at the district level, to ensure that there is good ownership at the health facility level of the approach, and it improves communication and coordination between the health facilities, service providers, and their communities. Next slide, please. After this design phase, it was important to maintain and sustain this local implementers' engagement into the actual delivery of the intervention, implementing and monitoring the community dialogue approach, as community dialogues are implemented by the community dialogue facilitators, right? There needs to be some leadership at the level of the health system. So during the co-design workshop, we actually worked with them to identify key responsibilities for each level: the health facility level, the district level, the province level, and the national level. And through these, through mapping very clearly these key roles and responsibilities, and as you can see, Malaria Consortium has no responsibility per se in the implementation of a community dialogue approach. It's really something that is led by the province level authorities, and Malaria Consortium acts as a facilitator, especially in ensuring that there is regular communication around what activities are implemented, not implemented, what are the results of the activities. So Junica has been doing a lot of work in terms of creating platforms for these local implementers to interact, such as a WhatsApp group. She's been working very much on compiling the different reports that come from the health facilities, from the community dialogue facilitators, and from the districts, and sharing that with the implementers, so that best practices are identified and people are motivated, and there is some kind of a team spirit created, like this is very community dialogue approach, and it's moving. Still some challenges are faced, especially the fact that neglected tropical diseases are neglected everywhere, including at the health facility. There is a lack of resources and of training of the health workers to actually diagnose and treat properly NTDs. This is not something they see as a priority. They have a lot of public health priorities in their health areas. So sometimes we have the feeling like the community dialogues are creating a demand for services, for attention to NTDs, but the health workers are not always able to meet. So this calls for continuing engaging with a national level, Ministry of Health, both the NTDs department and the health promotion department, to ensure that the NTDs get the attention that they require, and that the demand that is created at community level is matched by an equal level of attention at health services level. And we also need to continue engaging with funders and donors to ensure that there are resources available, not just for delivering biomedical interventions to control NTDs, but also to address equally the social and cultural determinants of vulnerability to NTDs. Thank you.
Thank you, everyone. We now have about 10 to 15 minutes left to address questions that have been raised during the presentations. And I just start us off. I think one of the questions that has been asked by people here at the webinar, but also a question we get asked a lot when we talk about this approach is, how is this approach different? How is it unique? How is it innovative? How is it different from other social behavior change approaches or community engagement techniques? And maybe Lauren, could you tell us a bit more about how we think this approach is innovative?
Sure, thanks, Christian. I think it was Glenn in our chat has raised the issue of empowerment. And I think this is a key challenge for SBC program implementers in terms of having the approach really live on and being sustainable. So in the case of the community dialogue approach, we feel that this is achieved from the outset in terms of having participation of all stakeholders in the design of the approach. This includes the community. So the community-based volunteers are really key for this, and having buy-in from the other community structures. And I think, as Glenn pointed out, this is really a staple in all SBC programming. Where the community dialogue approach is a bit more innovative is really in having that process of critically thinking about the individual experience of that community and having participants weigh in on the challenges they face on a daily basis and reflect more about what they can do differently given their circumstances. So I think the approach offers some tools for the community to be able to guide themselves through this process, depending on what the health issue is. So where this may be more facilitated externally in other approaches, this process really comes from the training of the volunteers who are not health promoters, but who are truly facilitators and leading the communities through this process of self-reflection. So I would say that's one of the main points where this approach is different from others. I think also, as Sandrine has highlighted in her presentation, the way that this approach is institutionalized, I think really sets it apart. So that starts from the formative phases, like was mentioned in Mozambique. We piloted this approach really with a lot of input from stakeholders at national level, at provincial level, district, and community. And all of this input has ultimately led to an approach which is now being recognized by the government nationally as key to improving health outcomes in Mozambique.
Thanks, Lauren. Another group of questions that have been submitted is around the role of the volunteers. So it's about eligibility criteria, but also their motivation to continue in the role and the satisfaction they may be getting out of this role. And I wonder if Sandrine could tell us a bit about her experience in Mozambique, about selecting volunteers and maintaining volunteers active throughout several months or even years of intervention.
Yes, thank you, Christian. Yeah, and I'd like to relate it to one of the questions I've seen from Antoine Villanueva about what were some common difficulties encountered when engaging non-leader participants from the communities. So what we have seen in Mozambique is that communities have been left responsible for selecting their own community-based facilitators. So they've been given a small list of criteria about what should be ideally the skills that will be required to be good community dialogue facilitators, and then they elected for their own processes the facilitators. Some issues we have had is that sometimes it's difficult to find the required level of skills within the people available to be volunteers in the communities. That has been a challenge, and especially to find women. Jenica, I think, can testimony that we have much more men than women. In terms of motivation to remain a volunteer, we've been quite lucky, I would say, or surprised, but these community dialogue volunteers have been volunteering and running 2 or more community dialogues per month in their communities since 2014. And we have a very low attrition rate. And this is mainly due from the research and the testimonies we have to the fact that they feel very much valued in their own communities to become a community dialogue facilitators, and they kind of change role in terms of social positioning. So we don't ask traditional community leaders or administrative leaders or teachers to be community dialogue facilitators, but normal community members, right? So by doing that, information is power. So by coming back to their community and running dialogues and have the leaders sitting at the same level as other community members and them talking, they actually gain some kind of social power or social positioning. That is the main, one of the main reasons for motivating them to continue doing that. Plus also the perspectives of knowing more about how and growing personally, maybe towards future opportunities to work in the health sector.
Thanks, Sandrine. I think you touched on sustainability there, and I think Lauren also made a few points that relate to sustainability, and it is a question that we've been getting as well. So what would we say about how sustainable and scalable this approach is? Maybe ask Lauren to get us started on this.
Sure, I guess the idea of sustainability has a couple different elements to it. It would be interesting to hear, in the case of Mozambique, what the plans are for the national harmonized approach and how that can be sustainable in terms of public health in Mozambique. I think the reflections on the motivation of the volunteers in terms of sustainability is very key also. And what we have seen from our experiences implementing in these 4 countries so far is that the communities themselves start to demand these activities. So as far as the motivation of the volunteers is concerned, that's one element, but also coming from the communities themselves to say, you know, we recognize this issue and we can use this platform to address other issues. So I think that's another element of sustainability.
Thanks. So Sandrine, would you like to add to that?
Yeah, I just wanted to add on how the community is actually involved in the community dialogue approach and its design. So I see another question about how the community contributed to program design in Mozambique. Well, I very much focused on the health system, program managers and workers and how we engaged them. But the first to be engaged were actually the community members. We conducted several formative research to try to have the community dialogue approach as relevant and yeah, as relevant as possible to the local context and to their needs. And all the feedback we've had from the community members, the leadership, and the community dialogue facilitators has been integrated into a continuous loop for refining the intervention, including, as I was mentioning, quarterly feedback meetings where we review that. And the beauty of that is that it allows the actual program managers, right, to listen to the voices of the community dialogue facilitators, and to become themselves much more aware of what are the needs, the priorities, the concerns of the community. As an example of that, we have seriously, I think, improved the delivery of mass drug administrations in these 4 districts of Nampula province, because now the community dialogue facilitators act as a liaison officer. It's just a matter of SMS or a phone call, so that the community is informed timely when a mass distribution campaign of drugs for NTDs is going to happen, when and where, and they do participate much more than what they used to do.
Thanks, Sandrine. I think we have time for one more question. There are actually a lot of questions coming through the Q&A tab. We won't have time to address all of them in this webinar, but we will go through all of them and put together a response to the groups of questions that are coming through over the coming days. But for now, I think a fitting question for the end of the webinar is to talk about the future. So what are the next steps? What are our plans for this approach? And I will ask all of the panelists to say a sentence or two about that, but I'll just get us started talking about Bangladesh. So what are our plans in terms of antibiotic resistance in Bangladesh? So there's 3 things we're thinking of doing in the next year or so. The first thing is to expand the community dialogue approach to not only cover the human health aspect of antibiotic resistance, but to also include the animal angle, so the use of antibiotics in livestock, for example. So we're thinking of adding content to the content we already have. A second thing we're hoping to do is to scale up the approach to a larger area. So at the moment, as I said earlier, it's 5 community clinics, 30,000 people, a fairly small feasibility pilot kind of studies. So we're hoping to expand that to a larger area. And then the third thing we're interested to do, of course, is to take this approach to other contexts, so to other countries, and to apply it to other health topics, because we think that this is a very flexible approach that's adaptable to different contexts and different topics. So that's the 3 things we're thinking of doing in Bangladesh. And maybe Sandrine, if you could tell us a bit more about Mozambique.
Yes, sure. So in Mozambique, in terms of immediate steps, the current phase of a community dialogue approach we're implementing now still needs to be evaluated, because we started a pilot with only 1 disease, schistosomiasis, but now we've integrated 3 diseases, which are lymphatic filariasis, schistosomiasis, and intestinal worms, soil-transmitted helminths. It's a lot. So we still want to evaluate and see if the community dialogue facilitators have managed to run dialogues integrating these 3 diseases, not all diseases together, of course, but to phase it properly. And we also want to evaluate what's the impact on uptake of mass drug administrations, which has been a problem in northern Mozambique, with people fleeing away when they see the health workers come to a village to deliver the drugs. So how the community dialogue approach in these communities has improved that. Sorry, I can't really. This is the first immediate step. The second step is to expand. Actually, there is a high interest of the Ministry of Health to expand this approach to districts that have low MDA coverage or specific entities problems across the country. And the last perspective we're having is to develop jointly with the Health Promotion Department a community dialogue model that would fit Mozambique and would allow to deal not just with entities, but also with other health issues, as you mentioned, Christian.
Thanks, Lauren. Thanks, Sandrine. Maybe Lauren, as our social and behavior change specialist, what do you see as the natural next steps that we could take to further refine this approach?
I would say this webinar is one of the first steps in terms of starting a dialogue with our colleagues globally about the best practices for social and behavior change. So as part of continuing this discussion, we want to share with you again the implementation guide for the community dialogue approach. And this is a step-by-step tool that can help you understand, first of all, if the approach is appropriate for what you're trying to achieve, and then secondly, how to contextualize it in your context. So when you look at the guide, you'll see a lot of these questions are questions you need to ask yourself when designing any community engagement or social and behavior change interventions. So really what we're trying to do is promote these principles that are included in the community dialogue approach. So we're quite open to continuing the discussion with our colleagues so we can improve the way that we do SBC.
Thanks, Lauren. And maybe finally, James, any final words about Malaria Consortium's plans for the approach?
Yeah, I would say that one of the things that we are keen on, and I think we've transitioned, is to appreciate the need for communities to be part of the solution, as I said right from the beginning. I think the era where we go into communities and tell them what to do and tell them how they are the problem or tell them how these are the solutions, I think that era has shown us that there's how much we can get, and there's significant things that the communities themselves can do to strengthen the community systems, but to find sustainable solutions. So Malaria Consortium is keen to continue using such approaches such that the partnership that we require between us, the communities, governments, and other stakeholders will create resilient communities, resilient health systems, and solutions that are sustainable beyond projects and can work at scale. Thank you.
Thank you very much, everyone, for joining today's webinar. Lauren mentioned that we put together an implementation guide for the community dialogue approach, which is available on Malaria Consortium's website. We encourage all of you to have a look at that. We encourage everyone to start thinking about giving communities a voice and getting them to talk about their health in their programs. And as Lauren said earlier, we very much would like to keep the conversation open, and we'd love to hear from you about any questions or any feedback you might have. So over the next 24 hours or so, you will receive an email with a link to the materials we've put together. We'll also try to respond to some of the questions we haven't had time to respond to today. And we will also make a recording of this webinar available. So we hope you found it useful. There's a feedback form that will pop up on your screens in a second. We'd appreciate if you could tell us your thoughts. But most importantly, thanks again for joining us today, and goodbye from London, Bangkok, and from Mozambique.